Good morning. I'm going to channel Carolyn Dennis and Forrest Calico. They've pretty much said things. I may say them a little bit differently, but we'll see how it goes. The committee places a great deal of emphasis on the word system. We believe a true health system should actually include a spectrum of health promotion and disease prevention activities, as well as the provision of health services. And in considering such a comprehensive system, as Elmer brought forward, there are three important words which we think ought to be kept in mind: responsibility, accountability, which we define as responsibility with consequences, and authority, that is the power to make changes in the system. We think that in any system of health system, comprehensive health system, there should be readily identifiable centers of responsibility, accountability, and authority. And to sort of test this out in a personal way, think about your own personal system of health care. Who is responsible for all of the aspects of my care? Secondly, who is accountable if things don't go right? And the third one, who has the authority to change the system of health care which I have? As Forrest has said, we believe that ultimately the health system should be accountable to the public. This is not always evident in present discussions. I'm not sure if there are any health systems in Kentucky which cover the entire spectrum from health promotion, disease prevention in populations, not individuals, population, health disease, promotion, disease prevention. But there are obviously many microsystems, that is, partial health systems. A doctor's office might be one such microsystem. A clinic could be another. A hospital could be a third. Each one follows its own agenda for patient care, and each one prizes its own autonomy, the silo concept that Carolyn mentioned. But to meet the definition of being a true system, they would have to be linked operationally and connected with effective information technology. The National Health Reform discussions which have been taking place over the past many months in public have made us familiar with some examples of system. A few. The Kaiser Permanente health system is one. It provides everything from primary to tertiary care in its own facilities. The facilities, the physicians and caregivers, but also the patients are linked by electronic medical records and electronic communication among all the sites which Kaiser Permanente operates across the country. Your records are available wherever in the system you go. Our committee principles, as was pointed out, we think are essential ingredients of a good health system. They come from the public, they come from Kentuckians. We have applied them initially to considerations of health care services, but they can also be applied to assessing health promotion, disease prevention elements in a system. All 10 are to be used together, as Carolyn indicated, as benchmarks for evaluating the current system, as they should be foundational elements in any transformed system we have. And unlike many things in healthcare, we intend them to be used as criteria for evaluation of the programs over a period of time. To be used operationally, however, there needs to be a way to measure the extent to which each principle is present in a given system. We're therefore developing measures and metrics for each principal in the form of questions to be asked by individuals in the community, or for the community. For example, to evaluate access or the ease of access, you really have to ask several questions. Is primary care available in the community? What are the hours of service at doctors' offices? Are there after-hour services available in the community? And if not, where are they to be found? Will doctors accept Medicare patients or Medicaid patients? Or will they be taking any new patients? All these things are relevant to access. And what about emergency services? Where are they available? If not in the community, where do you have to go to get them? And are there hospitals and other needed healthcare services in the community? Are medical specialists available in the community? And if not, again, what's the arrangement to receiving these kinds of services? And as you find particularly needed in rural areas, is there available and affordable transportation to health services? Finally, are there geographic, physical, cultural, or financial barriers to using the services? Each of these questions is a partial measurement for access. And we propose we are developing similar questions, measures, and metrics for each of the principles so they can be useful operationally. To ask someone if they have access without asking all the questions doesn't get you what you need to know.